Hello, in this video I'm going to be talking about hormone replacement therapy, or HRT. Before I go on, I'd love to invite you to subscribe to our channel. We put new content out a couple times a week, often in response to a comment or a suggestion from you. I also want to invite you to go to Yerbba.com to get your personalized report. Your Yerbba report will show you all the treatments you've received and the things you might be offered, as well as what to expect with each of those treatments. So hormone replacement therapy refers to the giving of people who no longer have functioning ovaries, estrogen and or progesterone. And you might be wondering, why would we do that in somebody with breast cancer? Well, there's a long history to hormone replacement therapy. For a long time, women were automatically given by many doctors estrogen and or progesterone, two so-called female hormones, to basically mimic a premenopausal status. There was a thought that was actually quite misogynistic, that women were no longer worthwhile without their estrogen. And a book called The Estrogen Cure was basically saying that women need estrogen until they die to make them feminine again. Then HRT became an option to control menopausal symptoms, help the bone, and help the heart. The problem was there had been no very large studies showing whether hormone replacement therapy was safe or not. The Women's Health Initiative, which was reported over 2 decades ago, randomized people to hormone replacement therapy versus placebo. This study has been critiqued, and it's also changed practice. So I'd like to talk about it just briefly. I think it's really helpful to understand the background. The problems with the Women's Health Initiative were that they enrolled people, the average age was 65. Now, we tend to go through menopause starting in our early 40s, with the average age being in the low 50s. So putting people on hormone replacement therapy on average 15 years after natural menopause was looking at an older cohort of people. The other thing is that the study screening for cardiovascular disease, heart disease, before people went on the study was done with an EKG, just a test of the electrical activity of the heart. That's not a good way to see who's at risk for coronary artery disease or other heart problems. So there are quite a few critiques about that study. Nonetheless, when the results came out showing no benefit in terms of decreasing fractures and showed an increase in the risk of breast cancer, hormone replacement therapy became a no-no for many patients and doctors. So regardless of what you say about the quality of the study and the way it was done and the special interests behind the study, it did lead many physicians and patients to basically put a pause in the use of hormone replacement therapy. And it's become taboo in many circles. In particular, in people with breast cancer, if we think about estrogen and progesterone in breast cancer cells can be sensitive to estrogen and progesterone, and blocking estrogen can actually lead tumor cells to regress or die, or breast cancer not to come back. So this has led to this really binary view: estrogen bad, no estrogen good. Well, as always, you can imagine it's much more complicated than that. So why are we even talking about this at all? It is important to know that your health and quality of life matter. And if you are miserable with hot flashes and other things related to no estrogen in your body, and in particular if you had a cancer with a low risk, a short-term period of HRT, hormone replacement therapy, may in your case be appropriate. I know this sounds like I'm busting dogma, and I don't mean to do that or to be confusing. But when we think about shorter term exposure, yes, I can't say the risk is zero, right? It's a non-zero risk. But we have to balance quality and quantity of life, as many of you have put in the comments. The other thing to know is that estrogen-only hormone replacement therapy does not appear to have the same risk in terms of breast cancer. So when we talk about hormone replacement therapy, as I mentioned, it can have estrogen and progesterone or just estrogen alone. Why would we use progesterone? Well, progesterone prevents people from getting cancer of the uterus or endometrial cancer. So in people who have a uterus, we do need to give progesterone. Unopposed estrogen only, estrogen alone, on the uterus is associated with a risk of endometrial cancer. So we don't want to cause another cancer. Estrogen only does not have that same putative role or cause and effect role as estrogen with progesterone. So estrogen only might be an option for people at low doses for short term. I just want to make a note about vaginal estrogen. Vaginal estrogen is another one of those very polarizing options. A small amount of estrogen used topically on the area around the urethra or the vagina and vulva actually can lead to thickening of the mucous membrane. That can make it harder for estrogen to get into the bloodstream. Nonetheless, some people on vaginal estrogen have had breast tenderness and have had relief of hot flashes. That means it can be getting through the whole system. So everybody's different. This is something, as this entire topic is something to talk about with your medical team and not just your oncology team. You may find your oncology team says absolutely not, but if you see a specialist gynecologist, you may actually be able to negotiate getting a small dose of estrogen to help you through a difficult time. I know this can be confusing. Put any comments or questions below. And as always, thank you for watching.